that more than 50% of all inhabitants have diabetes. Diabetes is a, yeah, diabetes is a so-called civilization disease. But this is mostly true about type 2 diabetes, which is combined with obesity and insulin resistance. Prevalence and incidence of type 1 is increasing, but much slower. So for taking figures from this country, we have about 1 million people with diabetes. Only between 45,000 and 50,000 have type 1 diabetes. The rest are almost type 2, about 850,000 people, and secondary diabetes or some genetical diabetes, the rest. So the increasing prevalence of diabetes is mostly thanks to increasing prevalence of type 2. Even type 1 is slowly increasing too. And you can see that in this bluish color, you can see that diabetes is now present in countries when you will not expect it on the first look. We have epidemic of diabetes in India, specifically in social layers of people who became the middle class. There is also epidemics of type 2 diabetes in Saudi Arabia, connected to also to the social movement and more middle class people, and easy access to sugar and to starch. So you can see that, and the same is that this was prediction, estimated prevalence. This is also true in China, where there are about, same as in India, about 300 to 400 million of type 2 diabetic patients. Type 1 diabetic type 1 diabetes is very interesting from the other point of view. It was completely deadly disease with 100% of mortality up to 1992, when insulin was isolated from pancreas, and every child or younger people, or also older people, we know now that type 1 is also present in older people, within months or maximally few years after diagnosis, died because of ketoacidosis. From this point, diabetes was the first disease with total mortality, which was cured by substitution therapy. We cannot cure the deficit of insulin. We will later come to that, but we can with substitution therapy with insulin somehow substitute this deficit. And now we have patients who are living for 60 years since their diagnosis from the deadly disease. It became be just manageable disease. Diabetes is quite old disease. The first traces are already in the Ebers papyrus. It is called after English archaeologist Eber, who found papyrus who described already some symptoms of disease like polyuria. The term diabetes is also pretty old. Greek doctor Arateus from Cappadocia, which is now in Turkey, described symptoms and brought the term diabetes. This diabetes is semantically interesting. This dia in Greek means that something is through or on the other side. It meant that someone is losing himself or herself through them. So people were vanishing, which was mostly Taiwan, that probably the time, because it was connected to catabolic situations, and they were losing weight and protein, and of course also fat, and then they died. So this dia is something, means in Greek something what is true. It's some, or on the other side we have dialogue, that you have a speech with someone on the other side, or diaphragm, that you have abdomen and thorax, which have barrier diaphragms through which are going esophagus and other structures. Or we have dialysis, which is where the fluid was this dialysis fluid with correct proportions of potassium and other minerals, and with low urea and creatinine and blood, but you can have dialysis with any other two fluids, and something is on the other side of the membrane. So this dia meant that you are losing your substance on the other side. Yeah, this is something what is not very correct. This is not describing it, but we use it as many terms in the medicine from the tradition. But it was a little bit interesting and for the fresh look, a bit funny. In the physical examination in the medieval time, and when medicine became very empiric, so doctors also had to taste the urine, which is difficult imaginably now, but they tasted it, and Thomas Willis, and do you know, he was a good doctor, practitioner, but he was good scientist, and then he made mostly neuroanatomy, and you know the Willis circle of the arteries in the brain. So this name is after him, and his most scientific work was done in neuroanatomy. But he tasted the urine, and he found the urine is sweet, and he called it mellitus, which is something like from honey in honey taste in Latin. It's very interesting that someone who was general practitioner, Swiss Johann Brunner, just have a strange hobby to make experiments on the dogs, and he made a pancreatectomy on the dog. He described polyuria, which was already that time known that diabetic patients are polyuric, but he didn't have this, this could be diabetes. He described it. The dog was certainly, after pancreatectomy, diabetic, but Johann Brunner was technically excellent, but didn't have this feeling that he found something very new. And already 1750, Matthew Dobson, English doctor, found sugar in serum and urine of diabetic patients. So those are the most important data. No one will examine you about it. What is important for the history of Taiwan is that Claude Bernard, from which we develop the scientific medicine, he made many experiments on animals, which now wouldn't be accepted by ethic committees. But at the time, he, for instance, took kidneys of the dogs and studied renal failure, or took away the liver, made hepatectomy, and studied the liver failure. So this was something of his simple paradigms. Took the organ away and studied the consequences. But he made many other. He described the reason of the glucose for the organism and glucose for the liver metabolism, which was quite modern. But he made something what was not proper. He made the function of the third ventricle of the brain, and he developed glycosuria. And he made resume of it that diabetes is a consequence of the brain disease, which was not correct, but it was for more than 30 years the paradigmatic sentence in medical textbooks. Probably the rabbit was in stress, and you should remember that in stress you can have in pre-diabetic patients, and sometimes this stress is extremely high, like in burn patients or in trauma, you can have higher glycemia in on previously non-diabetic patients. But this was done just because of curiosity of the Claude Bernard, who really made many basic and substantial steps to make medicine on the scientific basis. In 1875, Adolf Kussmaul described deep frequent breathing in a hyperglycemic coma, which was about 1875. He was German professor of medicine. And this is something what you also have to know, that there's a deep frequent breathing is a symptom of ketoacidosis. Before that, 1869, someone who was in your age or younger than you, I've got from his professor of pathology, who was a very famous German pathologist, Virchow, got for his doctor thesis topic the histology of pancreas. And that time was already known that pancreas has this exocrine function and producing the pancreatic juice. And Virchow asked Langerhans, who was last year student of the medical school in Berlin, to make more detailed microscopic anatomy of pancreas. In Germany, you will not get your MD so easy like in many other countries, including our country. You have to write the thesis. Even now, German doctors are finishing like with some license for doing medicine, but they have no title doctor. For the doctor, you have to make a thesis. And Paul Langerhans described specific islets in exocrine pancreas. He never knew about their role in the disease. He stayed to be pathologist. He very soon got a disease typical for pathologist that time, and even nowadays some pathologists get more often this disease than other doctors. Should anyone know what disease can catch pathologists easier than other doctors? It's tuberculosis. Tuberculosis are now treatable. By the time the only treatment was climatic treatment, Paul Langerhans went to I think he went to not to Mallorca but to Madeira. Started to be GP there, but the tuberculosis was proceeding and progressing, and Paul Langerhans died, as you see, in his age of 41, as he has a grave on Madeira. He never knew what he recognized. 1989, and this is very basic step in the knowledge about diabetes, and people were dying because of diabetes, and also children were dying. So it was very typical hunt for the causes of diabetes. Mering and Minkowski made pancreatectomy in dog. They wanted to follow the Claude Bernard theorem that take pancreas away, and they wanted to study some digestive insufficiency, like malabsorption. But they found, or someone who came in the room found that the dog after pancreatectomy was polyuric, and there was a white spot on the table. The assistant was not so scary, so he just took his finger and swept the white spot, and then put it on the tongue. He found it is sweet, and they describe diabetes after pancreatectomy. It was iconic step that pancreas has what to do with diabetes, not brain. They were punished for that. They were expelled from the university because it was in Strasbourg, which was the time, it is in Alsace, but the time it was German. And they were expelled because they were working against the iconic paradigm in the medicine that diabetes is a brain disease. They had to go away. They found places on the less prestigious universities. And from the time started the hunt for the substance. And something what is not on the picture, that in 1900, a Russian doctor living in Germany, Sobolev, made very simple experiment. He ligated ductus pancreaticus, and the pancreatic juice cannot proceed in the gut. So he found that there should be something what is a endocrine secretion. And endocrine secretion means that the hormone is absorbed in the blood and is distributed through the blood in the circulation. This was known already from 1855 from Edison. You know Edison disease, which he described. But he's also father of the term endocrine secretion. And later, then came slowly First World War. It was time for surgeons and also subjects like plastic surgery and orthopedic surgery were flourishing, and certainly not science, other science. After the war, someone who was orthopedic surgeon, Bunting, has not what to do, and he was waiting in his office for the patient, and they were not coming. So he was reading texts about diabetes. He found one very good text from Paulescu from Bucharest, who found how to ligate pancreas and later extract the hormone. So this Bunting went to the chief of the Physiologic Institute in Toronto and asked him, please give me 2 rooms, 40 dogs, and one medical student. It seems to be simple, but just imagine that you will come to Professor. Someone will come, orthopedic surgeon from our orthopedic clinics will come to Professor Schlamberova and ask her, please give me 2 rooms, medical student, and 40 dogs. So it will be never possible in the modern time because you need many procedures, money, you need ethical committees and qualification of the science, which Bunting certainly didn't have. But he had an idea how to what to do with the Paulescu idea, which was not already completely complex. He also found the chemist who was Kolib, who was able to isolate the substance. And then they somehow guessed that the substance is not possible to extract by acids or by boiling, how you can do it with steroid hormones, for instance, from thyroid glands, which was done for the therapeutical extracts already that time. So they used, they ligated ductus pancreaticus, which led to the atrophy of the external secretion. And after weeks, they made a pancreatectomy. And from this pancreas, there already were not active hormones. They extracted with mild acid, little bit warmer solutions, the substance which Kolib cleaned and crystallized, and later it became possible to treat the other pancreatomized ducks, and very soon they gave it to the patient, which in the modern time wouldn't be possible too. You should have thousands of different proofs, but they were able to go this way, and they started to save lives. Just for your imagination, if you will take the picture 11, you can see a boy who was 30 years old. It was about year after, on the December 1922. The boy has a weight 15 pounds, which is about 7 kilograms. And after 2 months of insulin therapy, he was nearly dying because of cachexia and ketoacidosis. And you see the same boy, after 2 months of insulin therapy, insulin started to be that time miracle. Now it is nearly boring. We have a very interesting thing in the research specifically about type 2, but it started to be very dramatic that time. And not surprise, they've got picture 12. They've got very soon, 1925, they've got Nobel Prize, but medical students at that time didn't get Nobel Prizes. So Nobel Prize got only Banting and the chief of the institute, McLeod. He gave them possibility and also good advices in experimental medicine. But the idea was of the Banting, a lot of work was of the medical student best. Banting and McLeod, they gave the part of the money to Best and to the chemist Kolib, but of course Nobel Prize is Nobel Prize. It was also without the money. We had the first Czech patients already in 1923 in General Hospital in Charles Square. It's very interesting that bedside of the bed of this first patient was that time medical student Jiří Silaba, who was 1945 founder of the second department of medicine, and also founder of the Czech Diabetes Society and Czech Diabetology. It's also Taiwan diabetic patients were no more dying. They could live months, years, and now we know that decades. And already 13 years after diagnosis, the diabetic glomerulosclerosis in diabetes, which was insulinopenic that time, now we call it Taiwan, was described as a chronic complication of diabetes. 1955 got a Nobel Prize Frederick Sanger from Cambridge. By the way, it's one of very few medical doctors or physiologists who've got 2 Nobel Prizes. He got later in 1961 other Nobel Prize. He described the insulin structure as a 2-chain A and B, and insulin was the first protein in whom the complex structure was described with the primary, secondary, and tertiary structure. And we know that chain A and B are connected with bisulfidec bridges. We know that in A chain you have 22 amino acids, and B chain you have 30 amino acids. And we will later speak about these amino acids, about these positions, because of modern insulin are made with genetic technology, changing individual amino acids. For exam, you have to know that insulin is protein. You have to apply it through injection. You cannot digest it. Even there are attempts to make insulin for oral use, but I don't think it will be extremely successful. So every protein you have to apply not enterally, you have to apply it parenterally. And you have to know that with amino acids, with changing of amino acids, you don't know to which amino acids are there, that changes of amino acids can change the property of insulin. And what is for our topic also important, that 1959, Samuel Berson and Rosalind Yellow found a principle of radio immunoassay. Insulin, they made it for insulin for the first substance, and they opened a fantastic era in the medicine, that since that we can hundreds and thousands of substances, find not only their presence but also quantitatively their level. This is a principle of radioimmunoassay, or in the modern time of enzymoimmunoassay. This was very silent revolution in medicine, but since that time we can describe the levels of hormones, mediators, and also drugs and other substances by the principle which was found 1959. It's very interesting. They didn't want to have money for that, so they published it in a scientific paper. Now, I suspect if they would work in a hospital or at the university, they would be sued that they made a finance problem that they didn't patent it and they didn't give the patent to the university. The same was 1922. You will think it was time of the really pure capitalism, but the university in Toronto, where insulin was found, sold the patent only for their expenses they had with insulin isolation, which they founded to the three companies always for $1,000 for this amount of money. It could be now perhaps 100 times more with inflation since that time, but still even all the companies, which is Eli Lilly in America, Novo Nordisk in Denmark, and Sanofi Aventis in Germany and France, they really each of company yielded billions of dollars since 1922 because of insulin is a substantial drug, and people with type 1 diabetes cannot live without that. And finally, if we are in landmarks of the how do we understand type 1 diabetes, finally Francesco Bottasso, who was Italian living in London, found that type 1 diabetes is a consequence of autoimmune insulitis, which is affecting only beta cells, not alpha cells and not the other cells in the pancreas. So just we have three now perhaps one other Nobel Prizes aspect of diabetes, which were awarded for diabetes and insulin. And now what we know about it for understanding what is type 1 diabetes or general diabetes. And since this possibility of radioimmunoassay by Berson and Yellow, we can understand that insulin secretion, that we have a basal insulin secretion, which is about 15 to 20 units. If someone doesn't have diabetes and have overweight like me, so they'll have more insulin, both basal and stimulated, perhaps 15 or 10 to 20. So lean people have 10, and people with overweight and have up to 20. People with obesity have much higher levels of basal and stimulated insulin. And you secrete insulin before you secrete insulin after the meal, and stimulated insulin secretion is also 15 to 20 units a day. So from this was developed, and I had specific privilege, was in Czechia to develop this possibility, or I brought it in from Germany, that time from Eastern Germany, and they had it from Denmark, that we are simulating in therapy insulin as insulin secretion. So principle of therapy of type 1 diabetes is to give insulin according to physiological secretion. This is something what very changed the therapy, which was hoping to give insulin once daily. But if you will give insulin once daily, you have to eat very regularly, not to follow to hypoglycemia. But if we started to give insulin in the basal insulin modem and bolus before the breakfast, lunch, and dinner. So we were able, step by step, to develop the system which leads to the treat to the targets which we have in diabetology. It's not possible to have it with one dose. We can simulate it with an insulin pump. Everybody of you certainly have seen insulin pump, but it's not possible to do it with one insulin injection a day. How we do? So this was how do we now understand the physiology? And if we will go back to picture 19, when we will look after insulin secretion in type 1, there is no insulin secretion, or some remnants of insulin secretion in the beginning. But after insulitis, nearly all insulin secretion is regularly distracted. By the way, we have about 1 million insulin islets. So most islets are on in body of pancreas, in corpus pancreatis. These islets have the weight altogether between 1 and 2 grams. It's a very small amount of tissue, and autoimmune destruction of such amount of tissue is not detectable by the symptoms. So many people are walking on the street not having any symptom. They have only antibodies, but we cannot investigate specific antibodies to everybody. Yeah? So this is something what you should know, that type 1 diabetic patient doesn't have any basal and any stimulated insulin secretion. He needs to have a substitution. So how do we make diagnosis? Signs and symptoms of type 1 are signs and symptoms of the lack of the insulin. And insulin is necessary for transport of glucose for the 2 types of the cells. Those are muscle cells and adipose cells, which have the glucose transporter 4. Activation of the glucose transporter 4 needs insulin. It's GLUT4 is insulin dependent. The other glucose transporters, we have now GLUT1 up to GLUT10, are not insulin dependent. We have about 280 different types of cells, and only in 2 types of the cells we need insulin for transport. But those two types, muscle cells and adipose cells, creates at about 50% of all cells in our bodies. Certainly, we don't have so much hair cells or nasal epithelium cells are certainly also less than adipose cells and muscle cells, etc. So we cannot transport insulin, we cannot transport glucose within the cells of muscles and fat, which means that the glucose from treated persons starts to stay in extracellular fluid. It's creating, it's increasing, it has increasing level in the blood, which means also increasing level of the osmotically active particles which are offered to the kidneys, which leads to polyuria. And that's why the patient with hyperglycemia is polyuric, and polyuria leads to the thirst, is thirsty, and thirst is very important symptom of the diabetes. And in extreme, which is now really very, very rare, it could lead to deep dehydration and hypovolemic shock. But in the other effect of the insulin, because insulin is blocking ketogenesis, glucagon, the other hormone, is facilitating the transport of the fatty acids within mitochondria and beta oxidation and ketogenesis, and insulin is blocking the effect of the glucagon. Physiologically, higher levels of the glucagon are more often in people who are fasting. Everybody who, even people without diabetes, in the morning have little bit higher levels of the keto acids, and in diabetic patients where there is lack of insulin or zero level of the insulin, there is no blockade of the glucagon effect, and they are very easily ketotic. Of course, we can therapeutic block it with insulin, but metabolic acidosis typically leads to, which is done by two acids, beta hydroxybutyrate and acetoacetate, is irritating the centers in medulla oblongata, and this irritation of the respiratory centers leads to deep and frequent breathing, which we do call Kussmaul breathing. Very extremely, in the modern time, you can feel the fetor, or the breath smells after acetone. Classically, it was called fetor acetonemicus. By the way, acetone is pH neutral, but it's developed parallelly to acetone, beta hydroxybutyrate and acetoacetate. We can find also, this is a pathophysiology of the symptoms, but for the practice, you can find high to very high glycemia, which is now very easy when you have glucometers in nearly every household. That the other members of the family, or in the office, or in the factory, in the school class, you can always find the glucometer. So diagnosis of diabetes, more type 2 diabetes, but it's very very often done by non-medical personnel. You find the ketone bodies in the urine, and of course, if you will investigate acid-base balance, you will find metabolic acidosis. Specifically in people who are presenting themselves with coma, we will later in complications speak about it. It's more often. Therapy. Then we have no, I will still make a once. You don't need to know the figure, but low C-peptide or raw insulin level is a typical. But there are signs of insulitis, and many patients with type 1 have specific auto-antibodies, which are, I don't know why it is not in the presentation. I will make it, which are GADA, EA2 antibodies, or zinc transporter antibodies. Do you see that? Yeah. GADA mean glutamate acid decarboxylase antibodies. EA2 antibodies are antibodies against tyrosine phosphatase. And zinc transporter antibodies are connected to one of the insulin transporter. We now use them for understand this is insulitis, and in very high percentage of the type 1 diabetic patients, it's quite clear. But if you have a lean diabetic in any age, so type 1 is a possibility. In the higher age, it could be also cancer of pancreas. But in a young age, up to 30, it's practically all the time type 1, with one exception, which is MODY diabetes. I will speak about it later. So generally, the therapy, substitutional therapy, insulin's protein has to be given parenterally. We mostly use a subcutaneous tissue of the extremities, both arms and legs, but also the subcutaneous tissue on the abdomen. Insulin could be given also intravenously, which we are doing in the case of the coma. So there are two basic possibilities. This basal bolus insulin that we give. Basal insulin mostly in most cases in the bedtime, and we use insulin which is keeping level 24 to 30 hours, or continuous subcutaneous insulin infusion given by insulin pump, where we are giving only ultra short acting insulin. Patient on the pump is giving bolus in the time when he is eating, so he is pushing a button on the pump, or sometimes he can or she can pre-program it, and the pump is giving the bolus, which is the same insulin which is continuously infused in the subcutaneous tissue. Now, a little bit about the types of insulin. Originally, original type of insulin was animal insulin. Of course, the first was from dog, but for the practical reason, it is necessary to take the insulin from the bigger animals, which were cows and pigs. So you could have a beef insulin and pig insulin. Of course, it was on the level of the time technology and science, but it brought many allergies because of you have to clean the insulin from the pancreatic tissue, and there were later chromatographic cleaning, and even there were antibodies against the insulin and allergy. So 1983, Eli Lilly came with a fantastic invention. They invented insulin made from the human gene technology. Earlier, the gene for the insulin, for the human insulin, was found and isolated and constructed artificially, then implanted in Escherichia coli bacteria. And as the bacteria is growing, it's producing more and more insulin, and then you stop because then bacteria will exhaust the nutritive substrates and is going to die or to finish its life. And then insulin is much more easily separated from simple bacterial bodies, cleaned and prepared in the further steps for usage in human body. It is fantastic third millennium technology, which started already 1982. It's something like the space odyssey in our field. Now we make or people who make different hormones and also the other proteins by this or similar technologies. You can produce, for instance, the factor 8 for hemophilia by this technology, and different, it's a long list of proteins which are produced by this technology. But insulin, again, was the first who started to be produced by this fantastic technology. And finally, analogs of human insulin were produced already 10 years after this human insulin. We call it human insulin because of structure. Biochemical structure of the insulin is identical to the human insulin. But if you will go to the picture 23, if you will change the simple amino acids in the insulin, and you will find the gene for it, just imagine, you have to find the gene. So you have to also change the gene and this changed gene to implant to Escherichia coli, or the other companies are doing it with other cells like Candida albicans or fibroblasts. And then you can produce molecules which have the changed amino acids, which allows to produce insulin, which are faster absorbed, or on the other hand, which have the long or slower delivery from the subcutaneous tissue. So we have now analogs which we can apply already before the meal, 15 minutes up to the beginning of the meal, or even sometimes during the meal if the patient do not remember to do it 15 minutes before the meal. And also we have insulins which can keep their level 24 to 36 hours. So patient is never without insulin and is not exposed to the lack of the insulin, so he is not in danger, or he or she are not in danger of ketoacidosis, because they are all the time covered by the certain level of the insulin. So these manipulations on the ends of the A and B chains is the third steps of the development of the different insulins. And analogs of insulins are now used for type 1 complete, without exception. In all countries of the Europe and North of America, and more people also in Africa and Asia are treated with analogs of the human insulins, which is for the question insulin therapy. In the picture 24, what types of insulin we have? According to duration of the effect, we have ultra-fast acting insulins. The beginning of the effect begins in 15 minutes after subcutaneous injection. Maximum effect is between 1 and 2 hours. And duration of effect is only 2 to 3 hours. It's similar how non-diabetic people, majority of you, is delivering the insulin to circulation. The only difference is that if you put it subcutaneously, you put it in the large circulation, and insulin is delivered from the pancreas to portal vein. So we have fast-acting insulin, which is so-called human insulins, which have duration of the effect 5 to 6 hours. And we have now long-acting insulin, which have maximal effect 4 to 24 hours, but they keep the effect up to 36 hours. So contemporary type 1 only analogs of the human insulin. And on the picture, there are names of the insulin from different companies. Side effects of the insulin: first is hypoglycemia and hypoglycemic coma, which is the nightmare of all diabetic patients and also diabetologists, because of hypoglycemia is very dangerous. Deep hypoglycemia under 2.5 millimole per liter is extremely dangerous for the brain, and still deeper hypoglycemia can in very short time to lead to damage of the brain and to make a patient a client of the nursing home, like hospice or etc. So this is something what we try to avoid. And of course, there are still some skin allergy, which could be hypertrophy or hypotrophy or fibrotic nodules. It was very frequent in the previous time with animal insulins, and it's quite rare. Even patient has to put insulin within different part of the subcutaneous tissue because of the sometimes fibrotization, which doesn't have what to do with allergy, but with small injuries with every injection could lead to fibrilization, and then the other insulin is not as good absorbed, so patient has to change the places of insulin application. Insulin pump, I suppose that everybody have seen the insulin pump now is not larger than credit card. It's a continual insulin infusion. We give basal insulin normally 0.6 to 1.1 unit per hour, but before the meal we give 4 to 6 units. And it's very interesting. The largest dose of the continuous insulin is between 3 o'clock in the morning and 7 or 8 o'clock in the morning, because of in that time the stress hormones are delivered automatically more often to all daily mammals, and we are daily mammals, to produce more energy from our energy stores. So that time the insulin sensitivity is lower. So we have to give to the patient, and diabetic patients are in that time most sensitive, because they without insulin and without active insulin they have ketose prone. So we have to give this 1.1 or 1.1 or 1.2 units an hour to most patients. And on contrary, in the afternoon, we are very often on doses, on the basal doses, which are the lowest. We used ultra-fast acting analog in the pump, as I told you, and this insulin pump needs to have 33 to 50% of all type 1 diabetic patients, because of they are not able to bridge the morning catabolic phases between 3 and 7 o'clock with a simple injection given at the bedtime. So at least 33% of all type 1 is now using insulin pump. Essentially, is blood glucose monitoring, which started with test strips. Everybody of you have seen the glucometer, and you need to have a puncture within the finger, which is after thousands and 10,000 punctures, big problem for some people. Now we have a continuous glucose monitoring in the last 2-3 years, when we put very easy sensor, mostly in the arm area, and this sensor could last now very easy to get proper information about glycemia for 14 days. You can have a glycemia every 5 minutes, and you took sensor which is similar to a smartphone, put it on sensor, and you can read it, and you can send it to your doctor, which was the way how I communicated now in the coronavirus time with most of my patients. What targets, and this is something, so technology in diabetes is a modern insulin, analog of the human insulin. Second, insulin pumps, allowing continuous continuous insulin infusion, and glucose monitoring. And of course, there are attempts. It's not yet definitely soluted, but people who are working on this scientifically, it's a very slow process looking for algorithm, which is not easy because, as I told you, even in continuous insulin pump, you have insulin unphysiologically in the large circulation, and physiologically it is secreted in the portal vein. But it's eternal dream to have a closed loop and to direct the insulin pump according to the glucose level. Now they start already pumps which are connected to glucose sensor, connected by radio sensing, and glucose sensor can stop the pump if the glycemia is going too low. And now this will be reality in the next 5 years in diabetes treatment for the most patients. Now we know it's already possible, and the fear of the very precise therapy of the diabetes is hypoglycemia. But if you will have a system which can stop the pump, so you of course you have to be precise and to do everything to avoid hypoglycemia, but you can have a still one break which is stopping the pump, which would be wonderful and to make and can make insulin therapy still safer. So the target, so technology, insulin, continuous monitoring, and insulin pump, and perhaps closed loop in the very near future. Targets which we have, therapeutic targets which you have to know. For example, HbA1c to 53 millimoles per mole, which for people who do not understand it properly, it means that you have a concentration of the hemoglobin you have in the moles. You have the moles of the insulin, and millimole is 1/1000th of the mole. So 53 millimoles per mole means that 5.3 persons is glycated, of the hemoglobin is glycated. Normally, every our molecule is glycated or glycosylated with glucose, but on bit lower level, normal level of the glycosylation of the hemoglobin is at 42. And most people have under 44, most people without diabetes. Our target is to have it on the level up to 53. It's still a dream, but we achieve it at about 50% of the patients. Fasting glycemia should be up to 7.7. Postprandial glycemia 9 to 10. I have here 9 to 9, but 9 to 10. There should be no appearance of hypoglycemia, which is very important target. And blood pressure should be lower than 130/80. We are very carefully, in every visit of the patient in my office, I see his blood pressure, and he and she has to monitor it home and bring me also a list of the blood pressure levels. Why do we are doing that? When we reach those targets, we diminish the development of the specific complications of type 1 diabetes, and about 1/3, about 35% of all patients on chronic dialysis are diabetic patients. Diabetes is a leading cause of the blindness because of diabetic retinopathy, and diabetes leads also to the neuropathy and diabetes foot, and all those three complications are very serious complications which can, without treatment, lead to the death or are increasing risk of the death. And we know that if we will, and we know it already for 40 years, when we will reach the proper targets, we are slowing the progression to this chronic complications. So I will finish that. 40 years ago, typical patients as a signs of serious retinopathy 15 to 20 years after diagnosis of diabetes. The same was the signs of the serious nephropathy, and the same was with neuropathy. And now, when we keep patients and when we try to lead them in therapy proper, and education is very important part of our therapy, that they have to know the disease, like doctors who are not diabetologists or betters very often. So we have the serious ophthalmic signs of the retinopathy 30 to 40 years after diagnosis, and it is still treatable by laser photocoagulation and can keep the vision the other 20 years. So you see that patient can have a type 1 diabetes, and in most cases, their sight is okay for 60 to 70 years. It's already nearly the lifespan. And the same is with the kidney disease. With a proper therapy of the diabetes and keeping blood pressure low, we are mostly using the AC inhibitors, which are lowering, which are lowering the. My telephone started to react on my remarks, which are keeping the filtration pressure in the kidney lower, so you can also postpone the appearance of the proteinuria for decades and postpone the necessity of the dialysis or transplantation. So that's why this is already not so dramatic field of the therapy. You are not treating coma, but it's very important that you bring diabetic patients to the normal life, which is not easy because they have to think all the time how much they have to eat and if to adapt the dose of insulin to the physical activity. But we have between our patients are sportsmen and are heavy working people or are people of every social level, and are much better prognosis than 40 years ago when we started with basal bolus intensified insulin therapy and with insulin pump therapy. We have now proper targets, and with this sort of the therapy, the life of diabetic patients is better. So it's now 10:28. I have to make a 5 minutes pause for me. I think you need to have also some pause, and we will start about type 2, 10:35. Okay? Thank you. And if you will have then any question, so please let me know. Ano, Juško. Čau. Prosím tě, oni mi to ještě neposlali z těch, oni to vyšování z plinárny, ještě není hotový, ale já jsem už se dostal, přes internet jsem se dostal k tomu účtu, který je jako pro Letohradskou, tak tam vím přesně, ten už jsem vytisknul, ale plinárnu ještě nemám.
Teď to nechápu. Takže máš elektřinu.
Mám účet za elektřinu.
Jo, a ten je kolik?
Ten je, co to hnedka řeknu. No, je asi... Já myslím, že asi 11 000, ale...
Dobře, tak jo, tak to nemůžeme s ním, já to chci dělat ještě jakoby, no, takže...
No, já ti to pak dám, ale možná, že můžeme skočit do plynárny a rovnou si to nechat dát a přečo to na tebe jednodušší. Jak se máte?
Jo, dobře.
Já teď tam už mám udělat ten polku. Okay, I'm here again. Do you listen me? Hello? Do you listen me?
Yes, we can hear you.
Okay. So may I start? In the beginning, before the type 2, I have still to. You have go to Viuka and we will open together the type 2 in Viuka. And I will tell you in the beginning still few definitions, which is good to know for examination and for the lecture. So in Viuka, we will state examination in internal medicine, and I have here the type 2 diabetes mellitus. So when we open type 2, yeah, I have it already and put it here. So if you would like to follow me on this type 2, so it could be helpful. Well, in the beginning, few definitions which belongs also to Taiwan. What is diabetes from the modern time? Diabetes is a chronic hyperglycemia. So if someone will ask you what is diabetes, diabetes is a chronic persistent hyperglycemia. Chronic means that sometimes in stress, in extreme stress, you can have also hyperglycemia in non-diabetic patients or previously not diabetic patients. Even many of those who have glycemia in stress are already people with worsening of glucose tolerance. But even the healthy man or healthy experimental animal can have with extreme stress high glycemia. So that's why it is chronic persistent hyperglycemia. The other very clear sentence is Taiwan diabetes is a chronic hyperglycemia as a consequence of destruction of beta cells. And the other sentence, destruction by beta cells is done by autoimmune disease. And probably what is a starting point of the autoimmunity could be certain infections which are affecting beta cells. It's very well known, for instance, about Coxsackie viruses. It's also known about, for instance, influenza virus could cause it. Sometimes also morbilli or parotitis. But typically, best known it's about Coxsackie viruses. Yeah, so those very few sentences about Taiwan and both chronic hyperglycemia is also typical for type 2. About epidemiology, I have already spoken. And we will now speak about the risk factors for type 2. It's about 6 million of type 2 diabetic patients in Germany. It's about 1 million or 800,000 here in Czech Republic. This increasing of the body weight in population, there are more and more people type 2 diabetic. What are the basic risk factors? Basic risk factor is metabolic syndrome, which has a insulin resistance as a basic cause, and basic cause of the insulin resistance is overweight and obesity as a consequence of the improper food intake. In laboratory, we will find very often hypertriacylglycerolemia as a risk factor of type 2. Risk factor and part of the metabolic syndrome is also so-called essential arterial hypertension. We know that with high levels of the insulin, the reabsorption of the sodium in tubular cells of the kidney is facilitated. And of course, part of the metabolic syndrome is already pre-diabetes and diabetes. So overweight, high triglycerols, arterial hypertension and diabetes are parts of the metabolic syndrome. But you can see the time development that you have in the beginning: overweight and obesity, which leads to insulin resistance with higher insulin levels, which leads to hypertriacylglycerolemia, to arterial hypertension, and to diabetes. Specific risk factors for type 2 diabetes are also polycystic ovary syndrome and gestational diabetes. In the picture 4, you have the risk factors of metabolic syndrome, which is high energy intake, specifically high carbohydrate intake, which is much higher than we have ever in history, but also low physical activity and sedentary lifestyle. So when you have a positive energy balance, this leads to storage energy in form of triacylglycerols, and liver and adipocytes can also create triglycerides from excessive carbohydrates. This is very important to know, that if you analyze the blood biochemistry and see higher triacylglycerols. The patients had even metabolic syndrome, or the other cause could be that has a higher intake of alcohol. It's a run for the genetic risk of the type 2, but with one exception, you see that there are many candidate genes, but you see that odds ratio is against healthy people is quite low, is about 20% higher. The only candidate gene which perhaps is really very much studied is this TCF7L2. You don't need to know it for examination, because I guess no examiner knows that. But generally, this gene is candidate. But the strongest predictor of future type 2 is a family history. If you have in your family history type 2 diabetes, you are in a risk of type 2. What could be perhaps coordination of many genes together, but we transfer from generation to generation not only genetic material, but also so-called MEMS. A MEM, like memory, which is a cultural memory, which is connected to the way of life of that family, which is very much often with a culture about, or connected to the food intake and food preparation and kitchen habits and eating habits, and also habits connected to the physical activity. So for many reasons, this family history could mean that this is also sort of genetic and cooperation of many genes, but type 2 diabetes is also a reflection of the living style, and this is very different in different families. The steps of pathogenesis in type 2 diabetes. First, from normal weight to obesity. This step is accompanied with increasing basal and stimulating plasma insulin levels. People still are not diabetic. They still do not have higher BMI, but they start to accumulate the fat in abdomen. Mostly it is typical already for the men between 20 and 30. As a way, the women starts to accumulate the fat in abdomen after climacterium. The men starts to accumulate the fats already since 20s. With this, the insulin levels are increasing, and as a reaction on the increasing insulin levels, so-called syndrome of insulin resistance is developed, and is developed as a consequence of the two processes. First process is chronic mild inflammation of the adipose tissue. If you will investigate the adipose tissue microscopically with a higher amount of the adipocytes, you will find the higher amount of the macrophages, because adipocytes, as more adipocytes you have, as more also apoptotic or sometimes even necrotic adipocytes you have. And you need to have the macrophages to decompose them, to phagocytate them, and to transport them, the remnants of them, to the spleen and to the liver. But macrophages are giving signals to lymphocytes, to T lymphocytes, to produce mediators, which are inflammatory mediators, which can lead to insulin resistance. In many aspects, one is also cellular response to exposition to high insulin, cellular response of the muscles, to the adipose cells, and little bit also liver cells, because of you have GLUT4 in the hepatocytes, but there are also GLUT1 in the hepatocytes, so the transport is ensured. But as a response to high insulin, the muscle cells and adipocytes are retracting their GLUT4s. So you have them more intracellularly, and there is less expression of the GLUT4. Some people means that it's a part of the defense against higher insulin and against hypoglycemia. Because of, if there would not be this reaction, patients will have more often hypoglycemia. But it is very well known that in the pre-diabetic period, this hypoglycememia is only mild hypoglycemia. People have perhaps blood glucose 3.7, 3.6, but it's provoking the appetite. And with more appetite, you have a more food intake, and then the circle goes on. So this is little bit defense against this, against consequence of the high glucose level. And high glucose level is a consequence of the higher food intake, mostly higher carbohydrate intake, but also higher fat intake in the acute model can lead to higher insulin secretion. So from overweight to obesity, the next step is pre-diabetes and then type 2 diabetes, and we will now speak a little bit for it. But this is one point, that you have an insulin resistance. This is one half of the insulin resistance is half of the pathogenesis of type 2. And second half is a damage or stepwise damage of the beta cells. And beta cells are damaged already in many people with overweight and obesity, which leads to situation that people who have initially higher insulin levels, both basal and stimulated, start to have a little bit lower. The insulin levels are still very high, but they are specifically stimulated insulin, postprandial insulin level, but also basal, are even higher than normal, but not as high as should be regarded to keep the glycemia in the normal level. So people have higher insulin levels, but insulin is not high enough to keep glucose in the proper proportions. Is anyone understanding it? So patients with type 2 diabetes have, in the beginning, higher insulin levels than non-diabetic, but little bit lower insulin levels than they had it months or years before. And then starts to be higher. Glycemia, we call it in the beginning pre-diabetes, and later diabetes if it's achieving specific levels like we will speak about it. This slow damage of the beta cells is continuing, and 30 years after diagnosis of type 2, and some people start with type 2 diagnosis in their 30s or 40s, so we have people who have diabetes for 30 years very easily now, and about 50% of them needs to have an insulin as a substitution therapy, which means that on the way, which lasted decades, more and more beta cells went to apoptosis or necrosis in some cases, and you have lower and lower insulin secretion, even though you started with very high when you were obese. What factors are leading to beta cell damage? We know it because we have excellent which are toxic for beta cells. Specifically, excess of carbohydrates leads to excess of free radicals, but also trans fatty acids are toxic for beta cells. Saturated fatty acids, like we know that palmitate is leading to apoptosis of beta cells, which could be blocked specifically by polyunsaturated omega-3 fatty acids and monounsaturated. So perhaps also low polyunsaturated fatty acid and monounsaturated fatty acid, which is oleic acid in rapeseed oil or olive oil or avocado, if you want. It's blocking effect of the trans fatty acids or saturated fatty acids on beta cells. There is a policy that people should eat less and less, and perhaps the best would be zero trans fatty acids and lower saturated fatty acid intake. It's also, it's not only prevention of atherosclerosis, but also prevention of the damage of the beta cells. But hypoxia of beta cells is regarded in the last years as a very important part of the story. We know, and this is not between the, I should put it on sleep apnea, which is typical for obese patients and for diabetic patients. And if beta cells are, after brain cells, most sensitive to second on the scale after brain cells, most sensitive to hypoxia. Sleep apnea, which is typical for obese people and diabetic, is destructing not only the brain cells, but also very probably, and we have Professor Clark have good experiments on it with the mouses in hypoxia chambers. Sleep apnea can probably directly lead to damage of the beta cells, and therapy of the sleep apnea could delay the diabetes in obese people. We are now thinking about the hypoperfusion of the pancreas in cases of the atherosclerosis of mesenterica superior, which is artery supplying pancreas. And of course, we know about the fat deposition with pancreas. And something what is not on this slide, what I have forgotten and I'm writing, it's amyloid of beta cell. About 15% of all patients who were abducted by pathologists and pancreas was taken off and beta cells were studied. So it was found that in 15% of all type 2 patients who died was amyloid present in the beta cell. It's a little bit different amyloid than in Alzheimer's disease, but some people are dreaming that this amyloid is perhaps specific disease and are speaking about type 3 diabetes. It's probably the same story, could be part of the also inflammation story. As I told you that as much you have adipocytes, as you have more macrophages and more chronic mind inflammation. It's not yet definitely known why, but it's known that 15% of all diabetics who type 2 diabetics who died have amyloid in their beta cells. Well, the next picture is also necessary for understanding Taiwan. Langerhans, as I told already, we have about 1 million of islets. They weigh 1 to 2 grams. Maximum are in the body or in the frontiers between head and body. So patients with pancreas cancer, which is distracting the tissue and leading to the local inflammation, could be presented also by diabetes. It's not type 2 diabetes, it's pancreas cancer. Beta cells are 50 to 60% of all islet cells. Artery supply from mesenterica superior. Venous blood flows through vena pancreatico-lienalis to the portal vein. It's just by the way, it was found the weight and total amount was found by Professor Ogilvie, who was Scottish pathologist, and he was invited to the first Czech diabetes meeting 1965 in Luhačovice in Eastern Moravia, and he during dinner found that he has a problem with a pain in epigastrial area. He felt that perhaps it was a consequence of dinner and went earlier in his room, and in the morning he didn't come to the breakfast. So Professor Silaba, about whom I have spoken, went to his room. It was locked, so when the room was open, this Ogilvie was already dying because of the pulmonary edema as a consequence of acute myocardial infarction. It was probably inferior myocardial infarction, which could have a pain in the epigastrium. At the time it was not known because there was no gastroscopy and there was no invasive cardiology. There's some very interesting. It's nobody will ask you about Ogilvy in the examination, and about this also no one will ask you. There are analogies between beta cells and nervous cells. They have complicated regeneration, which is different to mouse. They are sensitive to hypoxia, boys. Their energy metabolism depends on glucose. They have presence of GABA, which is glutamic acid butyrate, glutamate butyrate acid, and they have also glutamic acid decarboxylase, and they have ability to accumulate amyloid. It's very interesting, and perhaps also the nervous cell research and Alzheimer research will help to diabetic patients. I've many times there this picture. Well, now it was a little bit about pathophysiology. Signs and symptoms of type 2. Very poor. You can walk years with prediabetes and even with diabetes and feeling nothing. Higher glycemia doesn't make any pain. Prediabetes is nearly asymptomatic. And the only symptoms are laboratory. Higher fasting glucose or higher postprandial glucose or both. Type 2 could be also for years asymptomatic. Sometimes patients have skin or mucous infections, fungal or bacterial. So mostly you'll see balanitis in men or vulvovaginitis, mostly candidose balanitis or vulvovaginitis in women. But you can have also abscess or phlegmona of the skin. Sometimes you can have parodontosis. Sometimes dentists have a suspicion for type 2 diabetes. But very often first symptoms could be diabetic polyneuropathy, which certainly have to develop not for weeks, but for years. And specifically, if the patient have access to alcohol, combination alcohol and hidden type 2 diabetes can facilitate the neuropathy. Laboratory symptoms of prediabetes. Prediabetes has fasting glucose between 5, 6, and 7, and 7 and more fasting glucose means diabetes, but together with postprandial glucose over 11. Normal postprandial glucose or glucose in 120 minutes of OGTT is up to 7.7. Glucose 7.8 to 11 means pre-diabetes, and 11 and more means diabetes. If you have values over 11, you should repeat it, because of sometimes in the case of infection or tumor, you can find higher levels when infection is back. Diabetes or glycemia could be also lower, but you see that we use it arbitrarily, but a clever doctor looks on it a little bit dynamically. But for some diagnostic system, we need to know those three values. Or glucose tolerance test is done after 75 grams of glucose. You put it in 200 milliliters of water or tea, and critical values are fasting and 120 minutes. So we have some very few and very poor laboratory science, very poor clinical science, and you have to see the laboratory science. Basically, every patient who is obese or who has arterial hypertension or hypertriglyceridemia should be at least yearly investigated for type 2 diabetes. So to have at least glycemia or OGTT. What is the initial therapy? Diet, physical activity, and initial drug therapy is metformin. We always start with metformin. Basic guidelines for type 2. It's when we will start from water, you should give patient at least or in lean and of course in obese. If patient has 100 kilograms, have more water than the lean patient. Is 30 milliliters per kilogram a day. This is a norm. Energy should be lower than 25 kilogram a day. And in the modern diabetic diet, we have 35 to 37% of daily energy intake. Not as it is in many older textbooks, and I don't know any textbook where it is this with 35. We know that carbohydrate intake leads easily for obesity and for the fat accumulation. But it depends on the type of the fat. So carbohydrate should be maximum 50% of daily energy intake. Should be in the system of the diabetic diet. It should be 150 grams of carbohydrate or 200. Very obese people should have 150 grams of carbohydrate a day. People with overweight perhaps could have up to 200 grams carbohydrate a day. Most important carbohydrate is a fiber. Fiber should be 40 grams, but we calculated outside of the carbohydrates amount. Vegetable and fruit. And 400 gram vegetable is a general recommendation for everybody of vegetable and fruit, but more vegetable than fruit is recommended. Protein should be gram per kilogram a day. Only in people who has a progressive diabetic nephropathy with a protein losses, we give more protein. Saturated fatty acids should be less than 20% of the fat intake. You see, if it is 35% of daily energy intake, and it should be 20% of all fat intake, so it would be 7% of all energy should be provided by saturated fatty acids. Polyunsaturated fatty acids, both omega-3 and omega-6, should be 30% of all fat intake. Which should be about 10% of all energy intake. And monounsaturated fatty acids should be 50% of all fat intake, which is about 13% of all fat intake. Where you can find monounsaturated fatty acids, I already told, in olive oil, rapeseed oil, avocado, and nuts. Sodium chloride should be maximally 5 grams a day. So this is the basis for type 2 diabetic diet. Again, fiber, monounsaturated fatty acid, enough of protein, enough of water, and reduce energy than 25 calories a day. So then we have a, do I have still the physical activity? The best physical, because of people are mostly in their fourth, fifth, and higher decennium, so they are after 30, 40, 50 years of age, and often older. So the best way of the physical activity is a regular fast walking. Regular fast walking is miracle. At least 20 minutes every day fast walking, which means 5 kilometers per hour. It's not just walking around the shop windows, looking in the shop windows. It should be fast walking, really fast walking, as much as people can fast walk. Running in the people over 80s, to start with running, is not as easy, and you can provoke arrhythmia and cardiovascular death. And of course, biking is very good, but even biking is connected to serious trauma. Walking is safest and also easy, accessible way of physical movement. And you have to educate patients that they should stop use elevators coming up, perhaps coming down. They could do it. It's only distracting a little bit cartilage of the knees, but perhaps it's safer to go down with the elevator. Then it is not elevator, but it's also natural way of the movement to go to make steps if possible. And you can achieve very good results with it. So then the diet, and then the what to do, step 2 in pharmacology if metformin is not enough effective. So this is a recommendation of both American and European Association for Study of Diabetes and American Diabetes Association, that as a second step, you add, and it's not yet the recommendation of the Czech Diabetes Society, because this is very expensive. In people who have cardiovascular atherosclerotic disease or chronic kidney disease 3 and more, you should start with GLP-1 receptor agonists or glyphosines, which are the inhibitors of sodium glucose transporters 2. So what you have on the figure 22, if patient has cardiovascular atherosclerotic disease or chronic kidney disease, should add to metformin, GLP-1 receptor agonist or inhibitor of SGLT2. It's very expensive therapy, but seems to be very useful and has logic. The same should be done with patient with obesity. Then you can say it's nearly for every type 2 diabetic patients, and yes, it is for nearly every type 2 diabetic patients. And in other patients, or when we have lack of financial resources, in case of insulin resistance, if we have a patient with really cruel insulin resistance, and you can recognize it according to high triglycerides and difficult levels of the blood pressure, you can try pioglitazone. And if money is problem, which is in half of Europe and in most countries of the world, you have to add to metformin sulfonylurea or gliptins like sitagliptin or vildagliptin or linagliptin, alogliptin, and others, which are less expensive than Victoza or Jardiance. If nothing of this helps, then you have to go to insulin, and it has its ratio that patients are losing more and more beta cells, so you cannot get insulin out of the non-existing cells. So if nothing is effective, then insulin. Yeah. Yeah, I told that already. Earlier, that 30 years after diagnosis of type 2 diabetes, 30 to 50 of all patients are treated by insulin. The therapeutic targets or criteria for good metabolic control in type 2, HbA1c again less than 53, blood pressure is the same as in type 1, triacylglycerols less 1.7, cholesterol less than 4.5, total cholesterol, LDL cholesterol less than 2.6, and effective control of body weight. So this is something what, yeah, we will speak about complications still. It's necessary to say something what I didn't tell previously, that pre-diabetes has the same proportion of cardiovascular complications as clinical diabetes. This is also said. And it's very obvious that doctors made this real fault that they tell to the patient, it's not yet real diabetes, it's something like pre-diabetes, so be quiet and nothing is happening. No, risk of myocardial infarction or stroke is due to metabolic syndrome, very often higher cholesterol levels and of course triglyceride levels. It's the same like in diabetes. And because of 60% of people in Europe are dying of stroke or myocardial infarction, so pre-diabetes means the same risk for this as clinical diabetes. Clinical diabetes as even type 2 leads to more often to chronic complications of type 2, which is what we will speak now about complications of type 2 diabetes. Acute specific is non-acidotic hyperglycemic hyperosmolar coma. Could be, the osmolarity could be over 400 milliosmoles per liter, but there is no ketoacidosis. Ketoacidosis is not present because of many patients have still some traces of insulin, and even those traces of insulin can keep metabolism out of the risk of ketoacidosis. So they have extreme high glycemia, which could be sometimes over 80 millimoles of glucose per liter, but they don't have ketoacidosis. They could have sometimes lactic acidosis if the loss of water leads to deep dehydration, and deep dehydration leads to problems with peripheral perfusion, and peripheral perfusion problem brings less oxygen to the cell and can lead to hypo-oxygenic type of metabolism, so also for anaerobic glycolysis, and can produce lactate. But never you will find ketoacidosis in hyperglycemic coma in type 2. You will sometimes find lactic acidosis. Acute non-specific complication is infection. Type 2 diabetic patients have very often during the course of disease infection. You have listened certainly also now that type 2 diabetic patients were found to be more sensitive to COVID disease or COVID disease. And everybody thought, oh, he has diabetes, he got easily the COVID. Oh yes, type 2, even type 1, but more type 2 diabetic patients have many immunologic deficits like worsening of phagocytosis or glycation also of immunoglobulins and glycation of many mediators which are responsible for immunity. So specifically all diabetic patients, but specifically type 2 diabetic patients are more prone to different infections. They have more often tuberculosis, they have sometimes rare infection, but even normal banal infections like pneumonia or infection of urinary ways are more often in type 2 diabetes. Chronic specific, so this is non-specific. Chronic specific is diabetic polyneuropathy, could be sometimes the first symptom, diabetic kidney disease, and diabetic retinopathy. The asterisk in diabetic kidney disease means that in type 2, you will never find that diabetic glomerulosclerosis is the single reason for chronic kidney disease. It's always complication of the atherosclerosis, like vascular nephropathy, and type 2 diabetic patients are more, it's a basic risk factor for atherosclerosis. So vascular nephropathy is typical for type 2 diabetic patients too. And they also, because of tendency to infection, they have more often interstitial disease because of because of pyelonephritis, and also because of autonomic nephropathy, which leads to cystitis and ascendant infection to pyelonephritis. So those are, of course, those are most serious complications of even type 2 diabetes, and both of type 2 and type 1. And the last sentence, pre-diabetes and diabetes are both major risk factors of type 2. Well, now we have 11:30. I to be in contact with me, okay? But now it's time for questions. Have any question or also about the examination, I'm open to answer you now. So, no question about examination. Did you get my mail that, and Dr. Hoffmann asked me that we will have not the practical question, practical exam bedside, but you will get, and be prepared that you will get a case history. It will be simple case history, basal case history of the case you should meet during your studies, like polyuric patient presents himself with polyuria. Sometimes it's part 3 of the questions you are preparing, or patient came to your office with the pain during breathing on the top of the inspirium. What do you mean? It is cause. You should say if it is on the top of the inspirium, and if sometimes lead to the calf, it is syndrome of pleural irritation, and syndrome of pleural irritation could have could have 2 very serious backgrounds. First, a small pulmonary embolism with lung infarction, and second is a pneumonia. And you will keep your dialogue with the examiner. It never should go to deep details, but you should be oriented in the basic case problems. We applied it already during the first our first examination during COVID, and we were very satisfied with the knowledge of the students and with the ability to answer on the question from the real life. Okay? And the rest are typical exams which you had, which you have in SIS. You will get your credit from the chairman of the examination committee, and he will get it in SIS, and later he will also write your evaluation in SIS. So you will be invited not all together in the group of 10 or 12 people on one point. You will be invited in very small groups not allowing you to be in larger group. Even the restrictions are now much lower than 2 or 3 weeks ago, but still we will invite you on the specific time of the day for examination over next week. Yeah, because we don't know what will be happening with the disease, and we have to have the security that we will not expose you too much to the other students or to us. So you will be invited for the specific time. So that's, and on the other hand, the examination will have the similar course as any other examination you survived in the last 6 years. So any questions about this?
I have a question, Professor.
Yeah.
Regarding the people who are applying for a distant exam, like online exam.
You are in Prague or you are in your country?
I'm in Oslo. Yeah.
So it will be same. You will get the case report, and one of the members of the examination committee will keep before you, not numbers. You will not see the numbers, but you will say, take this, take this, and we will give you the number of question, and you have to and the only thing for the prescription for the exam which is from distance is that you will not have time for preparation.
Okay.
You have to this is a condition because against cheating. We are sorry to do this, but we didn't have. We already had 2 students in the late April who were examined on distance. They were Czech students abroad who took their practice abroad. In the beginning of the students of the exam, there will be short discussion what you have been done during the time of the last 2 months, or perhaps if you have any documents, you can send it to Mrs. Yeshkova.
Yes, I've already done that.
I think I've seen yours.
Okay, that's good. And also I have a question regarding diabetes type 1, if I can ask you.
Yeah, certainly.
You were mentioning the continuous glucose monitors and the insulin pumps.
Yeah.
Is it like this, that if you want to have the perfect control over your diabetes, do you use both the pump and the continuous glucose monitor on one patient?
Yeah.
So they have 2 devices, like one.
He has a device in the arm, and the insulin pump. Yeah. So there are now already some insulin pump in which they are not so easy accessible, but they are on the market, which have the insulin sensor connected to the pump, so they don't use the arm for the monitoring, but also subcutaneous tissue subcutaneous tissue in the abdominal area. Yeah,
understand.
But it was shortly before shown that the continuous monitoring is a crucial step to improve compensation or metabolic control of the diabetes, because a patient can every 5 minutes see what his or her glycemia. And he's more collaborative regarding the diet and also the proper insulin dose, etc. So you can have a glucose monitor and basal bolus system of therapy, which could be as effective as a pump. The only problem is with this time between 3 o'clock in the morning and 7 o'clock in the morning, as I told you, that in part of patients we are not able to resolve it with the insulin which is given on the bedtime.
Okay. Thank you.
Hello. Can I also ask a question?
Yeah. Could I see you? Is it possible to see you?
Oh, not possible at the moment. Sorry.
No, you don't have, yeah. So
Yeah,
the
I want to ask about we have a question about specific types of diabetes, and it includes inherited type of diabetes like MODY. I was wondering if you could just tell us, if you could tell us, elaborate on that point, like what's the most common type and what's the therapy that you offer these people, and what are the presentation and so on.
Yeah. So this specific forms of diabetes is not very good description, but it is given by diabetic societies and is textbooks, so you have to use it. Specific forms of diabetes are pancreatic diabetes, where there is a lack of insulin secretion because of problems with exocrine pancreatic tissue, like chronic pancreatitis or cystic fibrosis or pancreatic cancer. The other group of the specific types are endocrine types of diabetes, mostly connected to higher levels of the hormones acting against insulin, like Cushing disease. Or corticosteroid therapy, or acromegaly, or sometimes hyperthyrosis could have slightly higher glycemia. So those are endocrine, are very rare glucagonoma, which is very rare, one case in Europe a year and 3 cases in the United States a year. And then the other groups are genetic diabetes. And genetic diabetes is connected to MODY types of diabetes and to mitochondrial types of diabetes. Mitochondrial types of diabetes, it's called mitochondrial diabetes. They are connected mostly to women's, because they are inherited through the maternal line, and are quite rare and mostly present themselves in the childhood. And it's clearly that you will find more cases in a family. And then you have those MODY type of diabetes, which is mostly diabetes of the transcriptional factors. And this is MODY 1, MODY 3, and up to now MODY 6 or MODY 7. Most cruel are MODY 1 to MODY and MODY 3. And they have defect in so-called HNF alpha, which is hepatic nuclear factor alpha. I will.
Yeah, I have it written as well.
Yeah, HNF alpha, and you have I don't think you will be asked so in such details, but if Modi 3 has a problem with HNF alpha 1 and Modi Modi 1 has a problem with HNF alpha 4. And those are transcriptional factors for many, many proteins, including insulin. There are about 150 persons which are connected to HNF. And it's a problem with a transcriptional factor which starts to transcription of the gene for the insulin. Modi is most Modi cases present themselves in adolescence or in younger adult age. Typical age is 10 to 15. And typical is that because those are kids, that they are in the beginning regarded as a Taiwan. They have not tendency to ketoacidosis. And in the beginning, if the children are sometimes not very collaborative. So if they stop treatment with insulin, so not so much serious effect will happen. So then the children now find that they are not so much insulin dependent and start not to collaborate too much, which sometimes could create difficult problems. And we know now that we can improve the secretion of insulin with sulfonylurea. So we treat Modi 1 and 3 and 4 and other Modis with sulfonylurea, or in modern time with gliptins.
Okay.
The problem with those Modis is that they have complications like retinopathy or nephropathy quite soon. And that you have to have a very good metabolic control since the beginning to blockade the risk of complications.
Okay.
And Modi 2 is not diabetes of transcriptional factors. It's a defect of glucokinase, which is a sensor for glucose in beta cells, which leads to only lower hyperglycemia, like glycemia between 7 and 9, not higher than 9. Mostly almost around fasting glycemia around 8. It's not connected to typical specific complications of diabetes, this Modi 2.
Okay.
Yeah,
Perfect.
but that's
Thank you very much.
You should know about Modi 2.
Thank you very much. Thank you.
You're welcome. Still any question about diabetes or about examination? If you are still 19 connected, so I can expect there will be still. Silver, you have still question?
Yeah, I have another question. We have a question called polyglandular syndromes, and could you elaborate a bit on the diabetes? Diabetes connected to polyglandular syndromes.
Yeah. So you should start at polyglandular syndrome. We call it also APS, autoimmune polyglandular syndrome. You should know that there are 1 and 2, and you should read a little bit about it. But diabetes is a part of APS2.
Okay.
Very often connected to thyroiditis, and if you will histologically investigate, Langerhans islets and chronic thyroiditis, like Hashimoto thyroiditis, you will find very similar way of cellular infiltration. There are almost lymphocytes and few plasmocytes.
Okay.
And this is typical for this autoimmune syndrome. So, thyroiditis is the other symptom. The other could be adrenalitis, which leads to Addison disease. And there are some very problematic cases when you have together type 1 diabetes, Hashimoto thyroiditis, and Addison disease. It's together. It's called Schmidt syndrome. You don't need to know it, but Schmidt, like in German, Schmidt disease, and this could be typical. Sometimes you can find when there is a thyroiditis, you can find also vitiligo, which is connected to this syndrome because of specific autoimmune inflammation of melanocytes, which leads to defect of pigment. So this is something about APC, autoimmune polygonal syndrome.
Thank you.
In APS1, you have there is type 1 diabetes not so often. You have far more to thyroiditis and some other glandular involvement, also specific infections, which could be also fungal infections and problems with immunity.
Okay.
Okay.
Yes.
So, any other question? Looking.
Lactic acidosis and diabetes.
Lactic, there is a connection. Metformin. Metformin intoxication, suicidal or overdose with metformin can lead to lactic acidosis. This lactic acidosis is extremely dangerous. Mortality or lethality is about 50% with lactic acidotic coma after metformin. You shouldn't give metformin in patients with glomerular filtration lower than 1 milliliter per minute, or if you have a creatinine, which is not so precious, so in creatinine higher than 130. So if someone has a creatinine higher than 130 or filtration lower than 1 milliliter per minute, shouldn't get metformin. And there is also risk of combinations of metformin with alcohol intake. And specifically in patients with problematic renal function, alcohol intake, metformin, and problematic renal function can lead to lactic acidosis. If there is a case of lactic acidosis, patient is not in beginning not fully comatose, but has somnolence, which can which can rapidly lead to coma. And in the case of the lactacidotic coma, the only therapy is dialysis. So you should, dialysis should be arranged as a bicarbonate dialysis and should be done as fast as possible. Yeah, okay.
Okay, thank you very much. Also, another question in the chat is, are we expected to interpret test results during the exam? For example, biochemistry, spirometry, X-rays, or ECGs?
Well, you should know that in acidosis you have lower bicarbonate. You should know the normal ranges of the pH, of course. You should know that what is still compatible with life, which is pH 6.8 to 7.8, normal pH 7.4 plus minus 0.04. You should you should perhaps understand, including the basal parameters, the principles of the respiratory acidosis and alkalosis and metabolic acidosis and alkalosis. It's not so difficult when you will regard that everything what is respiratory has some movement in CO2. So if you have a higher PCO2 and alkalosis, it's which is pH over 7.44. So it is a respiratory because of higher PCO2 and alkalosis because of higher pH, and you should say that this is a respiratory alkalosis, and you should know the causes of acute respiratory alkalosis, which are very few emotions or some brain processes. Yeah, most of it's a emotion or could be brain tumor, or could be also encephalitis or meningoencephalitis. Yeah? And on the other hand, diabetic ketoacidosis is a typical with a deep pH, and when you have a pH under 7.36, it's acidosis. So you have to know this is acidosis. And if you have a low bicarbonate, so with a low bicarbonate, you see it is metabolic. And with high PCO2, it's a respiratory. And yeah, that's almost all you should know, and you should somehow understand what I think you will not be asked in the detail, but you should understand that, for instance, you have low bicarbonate in metabolic acidosis. And
Okay, thanks.
okay.
Yeah, another, like, the question I think was, will we be asked to like interpret a chest X-ray or interpret an ECG on the exam?
Yeah, it could be done in the practical part of the exam. Yeah, and of course, and you should know what is a understand the ECG curve, understand the intervals and PQ interval or and QT interval, understand the normal length and prolongation or shortening in the first case. Yeah, and then you should be able to describe what's happening with the Quer's complex during myocardial infarction, and you should be able to understand what are the signs of the hypertrophy of the myocardium in ECG picture, and you should know about the T wave according to ischemia or according to the mineral levels like potassium or calcium. And of course,
thank you.
you should be able to also to see that there is a shortening of the PQ interval and perhaps shorter PQ, and this VPW PW syndrome of pre-excitation and little bit understand it, which perhaps could come also in the specific questions of the arrhythmias.
Okay, thank you. And then the last one from the chat, Libby is asking, how important are statins really? There have been studies suggesting that they are not really as useful in some instances, and what your opinion is.
I didn't completely understood.
He's asking, how important are statins, statin therapy, and since there have been studies suggesting that they are not as useful as we may believe, and what your opinion is on that.
If statins are useful, or yeah, perhaps it's a very good question, but not the question for doubt about it during examination. We use statins. Statins, very probably statins are useful. Statins are lowering the risk of myocardial infarction. And statins are lowering also levels of the cholesterol, but it's question of the mechanism. And statins have have anti-inflammatory effect. And because of atherosclerosis is a chronic inflammatory disease, or has many aspects of the chronic inflammatory process. So many people believe that statins are useful, but the effect on the lowering of the cholesterol level is only byproduct showing that they are acting. But I don't recommend this discussion during state exam, because not necessarily every examiner has this idea or knows about these discussions. So in every case, and of course statins could be toxic for the skeletal muscle, can lead to skeletal muscle necrosis, and can lead to higher myoglobin levels and to kidney kidney disturbance, and eventually up to kidney failure. Very often the CK levels are a little bit elevated in many patients on statins. But even still, it is believed that it is better to use statins in the cases of hypercholesterolemia than not to use them, and that this is proper prevention of myocardial infarction and destabilization of atherosclerosis. Yeah, it's acting fast, and of course, I believe that the dietary approaches are basic, but duration of effectivity of the dietary therapy you can expect in months and years. But I have several patients who were not indicated to bypass or angioplasty because of too progressive form of atherosclerosis and already large narrowing. And of course, I gave them statins, but also very strict diet. And I have one patient who was found extremely risky for bypass or angioplasty because of so many stenosis on coronary arteries, and he's living 10 years, but he's regularly 30 minutes a day physically exercising on statins and very strict diet, and he succeeded to live already 10 years without any procedure. Yeah, but you see, to prescribe statin takes 1 minute work. To follow, to explain diet takes many minutes, many times, and there are many foods, and the patients have many questions and so on. So I personally believe that statins shouldn't be necessary if people would be on the proper diet, but it's very difficult in the modern world.
I was wondering, can they, if now there is a risk of COVID, can statins exacerbate or can they make like things worse, or they have no relationship with COVID at all? Because there was some studies that they somehow related, but what do you think about that? Sorry.
I didn't read nothing about these statins and COVID. There was an extensive discussion about AC inhibitors or inhibitors of AT receptors, like statins, because of COVID, as many other viruses, not only COVID, enters the epithelial cell through the receptor, which is ACE receptor.
Okay.
So if you treat patients with sartan, like AT inhibitor, or with inhibitor of ACE, like Prestarium, for instance, you somehow influence this way. There was already since February big discussion if it is positive to give or not. And the recommendation for the contemporary recommendation was continue in therapy with statins, with AC inhibitors or AT blockers, but not quite clear if new patients with hypertension should be given on those drugs, and perhaps the other drugs should be used in this time. But this is now change that, probably not serious interferences were found, which could be danger for patients. In statins, there were only few discussions, but perhaps I have read more about this and more about diabetes and COVID, and perhaps looking on Web of Science or PubMed would be bring better answers. So if you look now on the PubMed, or I can do it, so we will perhaps find something different. Yeah? Did you find something about statin and COVID?
No, it's still premature to say anything. So I was wondering what's your.
Yeah. But this there is sort of on the other hand, there is a lot of discussion about anti-inflammatory drugs and COVID, because of perhaps most problematic with the COVID is that in part of the patient you have too heavy inflammatory response to the virus, and those people with this over-inflammatory response, so it's also called as a mediator storm or similarly. So this storm is leading to appointment of the lungs and further problems with the lungs, like very distensive pneumonia. And it is questioned because of certainly cholesterol is inflammatory agent. If people and it should be studied, if people on the statins had a different prognosis than people on the other drugs, it seems be that transplant patients who have immune suppression, they were afraid that transplant patients will be first victims of the COVID, but surprisingly, they had no more COVID infections than the other patients, and if they've got it, they had milder course of the disease than the other people, or they were in the part of the people who had milder course of the disease, probably because of this immune suppression, which is blocking the inflammatory response.
Okay. Thank you.
Welcome. Any other question? Vitaly, you're going to be examined already next week?
Yeah, on Monday.
On Monday, yeah? I've seen you on the list.
Mm-hmm. Yeah.
So any other question, please? You should read about the treatment of Taiwan and type 2 coma, acidotic, ketoacidotic, and non-ketoacidotic. I didn't went to the detail. And if you would need to have some other specific seminar with me, which could be headache, which is on the slides, or transplantation, tell me or write me, and I can prepare similar seminar on these topics. Yeah? Okay. Okay. Also, thank you for your attendance, and goodbye and good luck.
Thank you.